Hey everyone, welcome to PathCheck Dice Global Health Innovators Talk Series. Here we talk about various digital health innovations in the space. Please visit the PathCheck website to know more about our efforts to mitigate the ongoing pandemic, and feel free to join our dynamic group of researchers at the link tiny.cc/PathCheck Slack. And if you'd like to visit the previous videos, please refer to tiny.cc/PCF Research Talks. So I'd like to thank my co-organizers for helping organize this event. So Professor Ramesh Raskar, Nise Hudson, Tauprate Sethi, and Nina Rasik. Thanks a lot for all the efforts that's put in. A quick intro about what GHI is. So this is a research meetup where we invite speakers of creating an impact on digital health with AI, software, and technology. The primary motive of the talk is to drive collaboration in AI for health with cross-disciplinary efforts by bringing in experts from computer science, medicine, bioinformatics, and more. With that, I'd like to invite today's speaker, Professor Milind Tambe, who's a Gordon McCoy Professor of Computer Science and Director of the Center for Research and Computational Society at Harvard University. Concurrently, he's also the Director of AI for Social Good at Google Research in India. He is a recipient of the HKI John McCarthy Award, the AMAS ACM Autonomous Agents Research Award, and the AAAI Robert S. Engelmore Memorial Lecture Award, among many others. He's also an ACM and AAAI fellow. Thanks a lot, Professor Milind, for accepting the invite, and we look forward to listening to your talk.
Thank you very much for inviting me. Let me share my screen. Yeah. So hopefully you can see what's on the screen right now.
Yeah.
Awesome. So I've kept this a 15-minute presentation, and I'll begin by, so the topic is using Restless Bandits to assist maternal and child care, but I'll begin by giving a slight overview of some of the work that we've done for a couple minutes before launching into the topic. So for the past 15 years, me and my research team have focused on advancing AI and multi-agent systems research for social impact, focusing on topics of public health conservation and public safety and security, with a challenge of how to optimize our limited intervention resources. So let me just jump into a couple of lessons. First, achieving social impact and AI innovation go hand in hand. Concrete example, in the area of public health, we have large populations to serve, but limited number of public health resources. So one example is work we've done with youth experiencing homelessness in Los Angeles, where harnessing the social networks of these youth, we are able to show that our influence maximization algorithms are far more effective in reducing HIV risk behaviors in this population compared to traditional approaches. This also required us to innovate in the area of social network algorithms and bandit algorithms. With respect to conservation, we have large conservation areas to protect limited number of ranger resources. Concrete example is work we've done in Uganda and Cambodia, where harnessing past poaching data, we are able to predict where poachers set traps or snares, and for the past several years have been able to remove thousands, if not tens of thousands of these snares. This work required us to innovate in the area of what we call green security games, which combines machine learning and game theory. In the past, in the area of public safety and security, we have contributed a new model called Stackelberg security games and contributed new algorithms that have been used by security agencies in the United States, such as the US Coast Guard, the US Federal Air Marshal Service, and others. These may seem like very different application areas, but they are tied together by the underlying set of techniques, which are drawn from the area of multi-agent systems research. A second lesson here is all of this work requires partnerships with communities and nonprofits. And some of the nonprofits we have collaborated with have shown the logos of here. Our ultimate goal is to empower these nonprofits to use AI tools and avoid being gatekeepers to AI technology for social impact. So with that, let me jump into the topic at hand today, which is maternal and child care in India. The situation there is difficult. A woman dies in childbirth every 15 minutes in India. 4 out of 10 children are too thin or short. We are very fortunate to be working with a nonprofit called Arman, which works with 25 million women in India. The program that we collaborate on with them is called M-Mitra. This is a weekly 2-minute automated message that is provided to mothers who enroll in this program. It's a message to new and expecting mothers in the local language. And it's something of the form, you are 3 months into your pregnancy, you should use this type of a health supplement. Or your baby is 3 months old, enroll in this government program. Mothers received 140 such messages from the time they enroll all the way to the time the baby is 1 year old. And in randomized control trials, Arman has shown that the M-Mitra program, where mothers listen to messages, leads to significant benefits to the mothers and their babies compared to groups that don't listen. 2.2 million women have enrolled in M-Mitra so far. Unfortunately, a significant fraction, and this is where we come in, of mothers who enroll become low listeners. 30 to 40% may become low listeners or drop out of the program. Arman has a call center, and the goal is how to optimize the small number of service calls that can be given from the call center to beneficiaries of this M-Mitra program so as to improve retention so that women don't drop out. So take this example. We have a large number of beneficiaries in this program, supposing 200,000 are enrolled. And we can only make 4,000 service calls per week from the call center to improve retention, to improve the mothers listening to these health messages. Which 4,000 should we choose? So here's an example, a motivating example. Imagine there's a health worker. She has 5 mothers under her care in this case. 4 of them, shown in red, have not listened to a voice message from M-Mitra. 1 has, which is shown in green. This health worker now can only call 2 mothers in this example per week, supposing she decides to call the first 2. This turns out to be a good choice because these 2 mothers turned to green. There's another mother who also turned to green. So overall, again, now she has to decide, this health worker, what to do next week. Given this situation, she may say, I will call the 2 who are in red. But this turns out to be a bad choice because what happens as a result is the 2 mothers she called don't pick up the phone, don't pick up get the message next week, so they remain red. And in fact, the 2 who were green also turned to red. They stopped listening. So choosing these 2 mothers to give a service call to was not a good choice. What's happening here in terms of challenges is that a service call from a health worker to a mother may not change this beneficiary, this mother's state. On the other hand, some mothers, some beneficiaries may change their state on their own from listening to not listening to these messages. Yet we have to prioritize 4,000 beneficiaries per week out of the 200,000. We turn to Restless Bandits to choose K out of N arms per week. For those who may not be familiar, to the Restless Bandit model, each arm of this bandit is a markup decision problem. So a mother can be in a bad state, shown in red, meaning she has not listened to our M-Mitra's voice message, or a good state. She has listened to that voice message, one of those 141 health messages. We can call this mother service call or not. And their transition probabilities from a bad state to a bad state, which is higher if we do not call. And if we do give a service call, the transition probabilities from a bad state to good state is higher. So in reality, we have hundreds of thousands of these arms. So we have a very large number of these MDTs. And we have to choose a small number of these arms to pull, a small number to give service calls to. Now, solving this problem in all its entirety with all these markup decision problems is extremely difficult. The problem is known to be p-space hard. So the way it gets solved traditionally is to compute a Whittle index for the current state of each arm. Essentially, Whittle index gives you the benefit of intervention. Technically, what it's trying to do is to compute the minimum subsidy that can be given in a passive state such that the benefit of not intervening is equal to the benefit of intervening. Once you have this Whittle index, we choose the top K arms, the arms with the top K Whittle indices, and pull them, meaning we give them a service call. To compute these Whittle indices, we use this algorithm we developed in AMAS 2016. Now, one challenge is that previous work normally assumes that the transition probabilities are all known. In reality, we don't have the transition probability of a new mother who walks into a mitra. What we do have is for previous beneficiaries, we know their features like age, income, education, etc., and their engagement sequence. They were in a bad state, we gave them a service call, they remained in a bad state, etc., etc. So from this past data, in a training step, we can cluster this data and then map the features into these clusters, which give us transition probabilities for each mother. So essentially, we have a mapping from features to transition probabilities for previous mothers. So when a new mother walks into a mitra, given her features, we can predict the cluster she belongs to, i.e. we can predict her transition probabilities. Once we have that, we can compute her Whittle index and then choose the top K mothers to call. Clustering gives us the benefit of compensating for lack of data and also speeds up our Whittle index computation because we are not computing a Whittle index for all the hundreds of thousands of mothers, but only for the clusters that we have at hand. All right, so we have the Whittle index on the basis of which we can give service calls. So how does this work in practice? So we've recently conducted a study with 23,000 beneficiaries, as far as we know, first large-scale application of Restless Bandits for public health. This is published in AAAI 2022, which is will be presented in February. We have 3 groups in this field study: a Restless Bandit group, a round-robin group, and a current standard of care group. There are 6,667 beneficiaries in each of these 3 groups. We pulled 225 arms per week for 7 weeks in each of these 3 groups. So in the RMAP group, which arms to pull, which mothers to call, was decided by their top Whittle indices. In the round robin group, we've called the first 225, then the next 225, the next, and it's a sequential calling that is done. In the current standard of care, no calls, service calls are given. This is the current standard of care, where essentially no service calls are given to mothers. And now we want to see how many more health messages were listened to by the mothers in each of these groups compared to the current standard of care group. And here are the results. On the x-axis are different weeks. On the y-axis is how many more messages were listened to in each of the groups compared to the current standard of care group. The blue is the Restless Bandit group. We can see that there's 600 more messages listened to in the Restless Bandit group, whereas in the round robin group, there's hardly any difference. Maybe 50 or so more messages are listened to. In fact, if you look at it in terms of statistical significance, the Restless Bandit group, there is statistically significant improvement over the current standard of care group in terms of number of messages that have been listened to. Whereas with the round robin group, compared to the current standard of care group, there is no statistically significant improvement. The point being that optimizing who you call, who you give a service call to, is important in order to have these mothers listen to more messages. And that is what the Restless Bandit allows us to do. We have an ongoing study with 100,000 more beneficiaries, and we are transitioning the software to Arman for their use. If you go to YouTube and look for this AI for Social Good in partnership with Arman video, you will see a very nice video. And I say it because the team which created the video is really awesome. And there, Dr. Aparna Hegde, the founder of Arman, is seen to say that we are able to reach out to more and more women each week and get them back into the fold and save lives because of AI due to the partnership we have done with them with this Restless Bandit. And there's also testimonials from one of the mothers who's enrolled in the program, how she got retained, and she talks about how I'll follow all the advice and take good care of my baby. There are many other possible applications of Restless Bandits. One other such application is tuberculosis. As we know, tuberculosis kills 500,000 people in India every year. 3 million are infected every year. And a TB patient has to take their medicine for 6 months in order to cure themselves of TB. And this is very, very difficult. I mean, I have difficulty taking a course for 7 days. 6 months is a very long time. And so again, health workers can be used from give calls from call centers in order to make sure patients are adhering to taking their medicine. So this problem is very similar. We have a health worker, she has many TB patients under her care, and she has to choose who to call every day. So she may choose the first 3 people here and find out that 2 of them did take their medicine last night and 1 didn't. And she can encourage them to take their medicines daily. And then again, she has to decide next day who to call, and so on and so on. This problem is very similar to what we just saw with Arman, except that the state of the patients is not known ahead of time. We don't know if they take their medicine last night or not. And this is a challenge of partial observability. So whereas in the previous case, we had Markov decision problems, now we have PALM-DP's partially observable Markov decision problems. We presented a solution to this problem in our MURIPS 20 paper and showed that we can come up with an algorithm, which is shown here in blue, which is significantly faster compared to the current state of art in terms of solving the problem with giving up very little in terms of solution quality. But there are many other very exciting problems. Another area of work is decision-focused learning, and I'll just briefly mention it and then stop given that I've exceeded my time. So normally in this work, as you've seen, we start with immersing ourselves in the domain, collecting data, and then learning a mapping from features to transition probabilities. And then we optimize and choose the top K beneficiaries. And then we evaluate. So basically, we first maximize learning accuracy and then maximize decision quality. First learn, then optimize, 2 stages. However, maximizing learning accuracy doesn't mean we maximize decision quality. Decision-focused learning allows us to modify the loss function to directly maximize decision quality. Rather than doing this 2-stage, decision-focused directly tries to optimize the top K beneficiaries that we want to choose. And we can show that this decision-focused learning leads to higher solution quality, even though there is lower learning accuracy as per the original metrics. There's a lot of further research to be done. I'll stop here. I wanted to thank PathCheck Foundation for inviting me. Thank you, Ramesh, for inviting me. Thank you, Rohan, Nina, for being here. And thank you to the audience for being here and listening to me. Thank you. So I'll stop sharing now.
Yeah, thank you. Thank you, Professor Tambe. This is a really wonderful example of high-tech, high-impact using some of the latest computational methods and demonstrating that they can make an impact in an area that's traditionally, although important, has lacked sufficient technology to really scale those efforts. I'll invite other folks to chime in, but I'll start with a couple of questions. I'm Ramesh Raskar, professor at MIT, and also the founder of PathCheck Foundation. I'm here with Rohan Sukumaran and Nina Resnick, who are also researchers in data and AI, interested in public health. So Milind, given the current pandemic, it feels like a lot of these ideas we should be able to deploy the Whittle matrix of transitions and using this Restless multi-arm bandits, we should apply them to other kind of pandemic challenges we have, such as second dose reminder or taking tests regularly and so on. Clearly, they may not have a call center notion of it, but there could be other nudges and interventions. So have you thought about applying the Whittle matrix, Whittle index transitions to pandemic problems?
That's an excellent question. We've thought about it a little bit in collaboration with Professor Maya Majumdar of Harvard Chan School of Public Health, but we haven't really had an opportunity to explore it in any depth, and we would love to find opportunities to collaborate and find ways to apply this technique, because it seems like restless bandits have a lot of possible applications in the area of health.
What are some common examples? As you know, behavior change, especially behavior change in health, is a exciting topic. At the same time, it's very difficult to get great results. So, what are some areas in which your team or other researchers have used these transition matrices for nudges and interventions in public health settings for behavior change?
I guess in terms of direct applied work, where we have seen examples on the ground, we are not aware of other applications of Restless Bandits, certainly not in the area of health. But we have done work with social networks, and I believe Brian Wilder came and gave a presentation earlier where use of social networks to spread information about reducing HIV risk behaviors. So we've done that work with youth experiencing homelessness in Los Angeles. So that's another example of actual deployed work. But the potential for using some computational techniques is vast. There are many, indeed, as you pointed out, there are many applications we've heard about where there is a nudges for exactly, that's a wonderful concept, nudges for behavior change. And there are many such examples that we keep hearing about. But I think it would be nice to actually see that experimented with in practice. And I guess this is one of the things in the area of AI for social impact that you and I are both fond of, that I wanted to highlight, that it is really important to test things out in the field, because otherwise we can write papers and be satisfied that this works, some technique works, but in practice, it may not actually work out the way we expected it to, because our assumptions are flawed in some basic way.
Yeah. I mean, all of us, including our group, got unnecessarily obsessed with models and prediction models, and but it's poor data in, poor prediction out. And this pandemic has proved all of us that the power of any predictive models is so limited in dynamic systems. So kind of continuing on the same track. So as you know, at PathCheck and many organizations now, you're at Google, the digital engagement of a consumer, or in case of pandemic, kind of digital engagement with a citizen or a resident is an untapped opportunity. And so at PathCheck, we believe that if we can use digital technologies to solve other problems, e-commerce and hailing a taxi and buying your favorite stock, which are all related to behavior change, all related to self-orchestration. Why not an app for public health? Any guidance you have on how this app should be developed? There are already a few apps on kind of symptom tracking or when you check in, of course, vaccine credentials and so on. But what are your suggestions on what are some good AI data science methods that should be added? These are still early days, but could be added to such apps.
Yeah, I have, many of the lessons that I'm going to speak about, Ramesh, very well, but I thought I'd repeat it. The first one is partnership, I guess the first three, with the local communities, local organizations. Because I have seen far too often that technologists will come up with a solution in the lab which looks awesome, and then go to the field and realize that it just violates some very basic assumptions that are there. That people are unable to use their solution. And so that, it has to be the top priority to build these applications in partnership with local communities, with local nonprofits. And we try to adhere to that principle as much as possible. And sometimes you still get tempted to do something which is purely technologically nice, but that's just often a recipe for things not working out. I guess outside of public health, maybe as well, partnership with other scientists outside of computer science is often beneficial. Visiting sites where the application is going to get used is often eye-opening because it just sort of makes clear what is the context in which we are operating. Making sure that the app fits into the normal workflow of the organization for which we are trying to build it is useful. So there are all, one of the other things is, lack of data is a norm. It's a feature of these kinds of domains, and we have to be used to it. I have certainly seen sometimes some students come in and they sort of say, well, but I can't work on this problem because there's not enough data. But that is the point. There is not enough data, and you can't just say, well, I will not work on this problem, because many of these domains are exactly as you just pointed out, Ramesh, that they just lack data. So these are some of the lessons that we have learned, and yeah, these are things that we want to be watchful for as much as we can be.
So if I heard three top things, and not in the same order that you presented, but three top things, app developers should think about when they're developing a public health app is assume there's lack of data and compensate for that from day one. Think about partnerships, because you can do very iterative development. And third is for behavior change, see if there are mathematical or data science principles that you can use, as opposed to launching something and hoping it will kind of grow on its own.
Yeah, and I guess I find that working with, in my case, it is professors of social work, or in the case of conservation, it's conservation biology or public health, has been most fruitful, rather than relying purely on computer science intuitions.
Yeah, there are too many of us, at top institutions, and that's not enough. Let me ask a bit more. We have some really great attendees. I encourage them to type their questions, and at the end of the call, after we stop the recording, we'll bring you on video. But feel free to type your questions right now. A little bit more, a technical question, which is, you looked at multi-arm and thinking about the control arms, kind of, in simple words, kind of A/B tests. In A, you do the intervention, in B, you don't do the intervention. Often there's no such luxury, especially in the middle of a pandemic, in the middle of a public health crisis. And traditionally, observational data could give you some initial inclination, especially if the interventions are, not life-threatening, like giving a cancer drug or not. Here we're talking about nudges and behavior change.
Yeah.
What are your thoughts? Can you give us a somewhat detailed answer on how people are thinking about it? Correlation versus causation, controls versus observational. What are your thoughts, and how that plays into today's data science and AI?
No, that's again awesome question, and there are clearly such settings where an A/B test seems very problematic. I'll draw from one other area of work that we are involved with, which is human-wildlife conflict, which is completely different. But I thought I bring that up just as a completely different example, where you can imagine that we are trying to predict and intervene on preventing human-wildlife conflict, which is a major problem, for example, in India, and if you try and do an A/B test there by saying, oh, we'll give some ways of preventing, wildlife conflict in one case and not in another case, and see who lives and who doesn't. That doesn't sound like those sorts of. So I totally understand what you're saying, Ramesh, in terms of being very careful. Obviously, there are different kinds of experimental design. I think, the kind of test that we ran in order to get the statistical test was a linear regression model. There are more complicated models that can try and get at the causal versus, causal relation, trying to get at the causal relationships between the factors, so that at least we are sure that, to the extent possible, that what we are seeing in terms of the differences we saw are not due to some inherent features in the different groups, like one group has more people of type X versus Y and things like that. And so we would, want to make sure that as we go on, that people get trained in all of these kinds of experiment design and, understanding causal relationships and understanding statistical significance and so forth, in order to conduct this kind of work in the field. I do see a question in the chat, so I can go ahead and try and answer that. So I see from Meg question that talks about whether geospatial factors were considered. And we did not. That's an excellent question. Right now, we are being agnostic as to where people are living. And you're right that getting some of that information may allow us to do a better job with the transition matrix. So the way currently the transition matrices are predicted is by clustering people based on their features such as education, income, age, how many children they have, but nothing that relates to their lat long or their geospatial considerations. And so that's interesting. Word of mouth is also an interesting question that relates to social networks and bandits being brought together. In the current context, we don't see any evidence in this group of people who are enrolled, group of beneficiaries or enrolled within the Mitra program, that there is a word of mouth that the mothers are talking to each other and spreading information. That's what we've been told. But the problem of combining bandits and social networks is technically very interesting and something that should be explored, because I'm sure there are applications where that would be very valuable in terms of a technique.
Your team did some work with Mina Lab and others on which tests are more efficacious, whether less accurate rapid tests versus slow but more accurate PCR tests. Anything in that direction that you can give us a preview, or your new thoughts, or even you think what you did in the past could be modified?
Yeah, I guess first, just to repeat what we did, it was certainly Michael Mina who, we totally want to make sure that it's Michael Mina who led the work, and we were just very glad that we could assist him with some modeling effort. So the result of that work that was published in Science Advances, January 2021, was to show that if you have a campus like Harvard, and we want to see, what kind of test should we run if we are going to test all of the students and isolate them based on them being turned positive. So every 3 days, if you're going to test everybody, you could do rapid tests, or you could do more accurate tests. So more accurate tests, more accurate in the sense of PCR, so forth, they detect lower viral concentrations. If we could get back results instantaneously, and if we could run the test at the same frequency, then indeed the more sensitive tests are better, because we could isolate people at the same frequency. However, the more sensitive tests are more expensive. They take a longer time to get back results. And just that delay, 24-hour delay in getting back results, implies that there's a delay in isolating positive individuals. And as soon as that happens, all the benefit of these more sensitive tests is lost, and rapid tests in the model turn out better. Furthermore, because of cost, if the more sensitive tests can only be run at a slower rate, lower frequency, then again, their benefit is lost. In other words, rapid turnaround time and rapid frequency or more frequency is more important than sensitivity as it comes to COVID testing. That was the point of that paper. And Michael, everybody knows, has been spearheading this effort to try to get rapid tests, and has been advising governments and all sorts of, and it's such a tragedy that we still cannot get rapid tests. I mean, we did this work in summer of 2020, and it's just like I go to the local pharmacy, and sometimes there's nothing. Sometimes I go there, and one time I tried to buy 2 packs, and they said, no, you can't buy 2, you can only buy 1. And it's just sad state of affairs. So I see a question from Rohan, which is nice. How was the drift in data handled after the model was deployed? It's a good question. We will have to monitor the drift in the data. I mean, right now, the way we have been thinking about it is that we will basically, every time we get a new set of beneficiaries, we will rebuild the model, learn the mappings again. But if there should be some, I mean, so this needs to be a dynamic mapping from features to transition probabilities. And it's an excellent question. So right now the way it's happening is that, okay, we'll, after a few months, redo the whole thing. But if there is a more dynamic way so that it's a slower shift, that
I think we lost Milind.
Yeah.
Excellent. So those who are listening, feel free to type your questions in the audience. We're going to stop in about 10 minutes. So feel free to go ahead.
I think there's some sound right now.
Yeah, Milind, we cannot hear you right now. So we don't have, in Cambridge, we don't just have challenges in getting rapid tests in stores, but also the internet connection, because too many companies and too many top universities here. So let's see. I think we can probably wrap it up, Rohan. I think it's kind of just amazing the work that Professor Milind Tambe and team at Harvard has done, and his partnership with other nonprofits, especially in India, is inspirational to us. And at PathCheck Foundation, we have a similar mission, which is how do we use data and technology to accelerate some of the impact of these efforts. So let's, Rohan, we can wrap it up, and then after we wrap it up, we can allow some of the participants to come back on video after we stop the recording.
Right, makes sense. So again, thanks everyone for attending. And in case you missed some parts of the video, please check